all of you for deciding to spend some of your Saturday morning learning about a super weedy policy issue that is very important to the bleeding disorders community, and issues that I and folks at NHF and the Alliance, and I know many of you have been working on for a very long time. But as we were kind of joking before this session, it's a little bit dry, the title. I'm hopefully going to make it a little more exciting. You know, and as Sarah said, please feel free to chime in with questions as we go. I'm a pretty informal person, hoping that this can be more of a discussion than a presentation. Let's see if I can. So what will I talk about today? The goal of the session is to tell you about skilled nursing facilities, why people with bleeding disorders need them, and then why there have been access issues in the past and how we have tried to respond to those access issues in federal policy making recently. There will be time at the end for Q&A, both on SNFs, but as Sarah mentioned, I do federal policy work for NHF and the Alliance and work on lots of other kinds of things. So if you have questions about anything else happening in, you know, wacky Washington, I'm happy to answer them. But I am going kind of deeper on the SNF issue today. And I know some of you may be HTC staff for whom this is all super familiar. This is something you work with day to day. Some of you may be community members where all of this is new. So I wanted to start by just kind of defining terms. When it comes to health policy, there's a million acronyms, a million complicated things, and I'm going to try and explain them all as I go. But again, hope that people will let me know if there are questions. So what are skilled nursing facilities, or SNFs? SNFs are not nursing homes, but they are a type of hospital that provides intensive inpatient, so that means people are admitted, nursing and rehab services. And so the idea is that they provide a higher level of both medical care and nursing care beyond to what is available for people treated at home. So at SNFs, patients can get medication, occupational therapy, physical therapy, help with dressing changes after surgery, as well as what are called activities of daily living, getting dressed, going to the bathroom, brushing teeth, eating, things like that. To give one example, my mom about a month ago fell and fractured her pelvis and then had to have surgery to have screws put in. And we talked as a family about whether she should go to a SNF because she couldn't walk, she was in recovery, she needed help, et cetera. So that's the kind of situation where someone might go to a SNF. Doing policy updates, my slides are often pretty boring. So the last thing I do is go to Google Images and try and get pictures to put on to try and liven them up. And so if you Google image search, skilled nursing facilities, these are some of the pictures that show up. But I should say that it is not just for the elderly. It could be someone of any age who needs help recovering from a surgery, a joint replacement, a knee replacement, you know, things like that. There's kind of an alphabet soup of other types of long-term care settings that I'm going to mention a little bit later on. So wanted to take a second again and just kind of define terms here as well. So other types of long-term care settings include long-term care hospitals. They are like regular hospitals, but they specialize in treating patients who are admitted for more than 25 days. So for people who are in for much longer stays than normal. There are also IRFs, or inpatient rehab facilities. Those are hospitals that provide intensive rehabilitation services. If you as a patient want to be admitted to an IRF, again, say after a joint surgery, you have to be able to demonstrate that you can do a couple hours worth of physical therapy every day, which depending on how you're feeling and what what procedure you had done could be hard. So sometimes people go from the acute hospital, the regular hospital, to a SNF, and then as they're better to an IRF when they really are focusing on rehab. And then there are inpatient psychiatric facilities, a totally different kind of facility, obviously, than what we've talked about so far, but another type of hospital that people can stay at for longer. And I should say that these are all definitions used by the Medicare program. Much federal policy starts with the rules for Medicare, which is the federal program for the elderly and disabled. And then the rules in Medicare kind of trickle down to both private insurance as well as Medicaid for low-income people. But when you're looking for kind of what are the rules, often we start with Medicare. And as I'm going to explain in just a sec, because Medicare has really particular rules about skilled nursing facility reimbursement, that's why we focused our advocacy effort there. Also where we were hearing from community members that they were having the most challenges. So why would someone with a bleeding disorder need a SNF? Again, this could be someone who was hospitalized and they're not able to go home right away because they need more care. I think most commonly this is surgeries related to joint damage. But I'll say that I've heard stories from HTC social workers about a variety of different causes that someone is in the hospital. It's not quite safe for them to go home. Their family's not able to care for them, or they need more care than can be provided. And so the skilled nursing facility is the best place. So often, again, saying something that I suspect everybody knows, it is HTC social workers who get involved at this point to try and figure out, what's the best setting to meet the needs of the patient. Again, sometimes that could be a rehab hospital. So again, you have to be pretty healthy to be able to do significant amounts of physical therapy every day. So that's where SNFs often come in, that we want, that an HTC social worker wants someone to be able to go. Let's see. So why have there been access issues for Medicare beneficiaries? And as I was looking for a picture for this slide, I thought what I really need are pictures of weeds, because this is when we start to get like super, super weedy. I mean, this is more information than anybody really needs to know, but it provides the context for what the challenges have been and how we've been able to address them. So it all comes down to how SNFs are paid by Medicare. Medicare pays them basically a daily rate called a per diem that changes a little bit based on the diagnosis of the person who's been admitted and the treatments that they need, but it's really pretty low. It also varies a bit on where you are in the country, but we're talking, $100 to $200 a day, which is supposed to cover their room and board, the nursing services that they receive, and any PT and OT, everything is supposed to be covered by this one daily rate that SNFs get for each day. And the problem is that, there's a whole complicated process where Medicare sets what that daily rate is each year, but that is supposed to cover all of their operating and their capital costs. The idea is that if you are a good SNF, if you're efficient, if you have a well-running program, you'll be able to cover your costs for Medicare patients based on that rate. And the problem is that, a couple $100 a day is obviously way too low to cover the cost of bleeding disorders treatments, because that daily rate is supposed to also cover any medications that someone gets, with some exceptions. And we have heard estimates as high as $10,000 per day immediately after a major surgery, where someone's really recovering from something. They might need a lot more factor, maybe just for a couple of days or for a week. But SNFs, if they were to accept someone who has Medicare with a bleeding disorder, that couple $100 a day doesn't come anywhere close to covering the cost of their treatment. And so as a result, SNFs often just don't accept people with bleeding disorders who are on Medicare. Again, shout out to the social workers. They understand, this is where my patient should go. They call, explain the situation, and SNFs just say, no, I'm sorry, we're not able to take that patient. And I'll talk in a second about, so what happens then and what the repercussions are, why we've been trying to solve this problem. So how many people are affected? Whenever we're working on a federal policy issue, and I think this is true on the state level too, and Sarah can chime in the Q&A if I'm wrong. We often try to marry compelling personal stories with data, because I think it's personal stories that really interest a policymaker in wanting to tackle a problem. But you need to have data to support it, so they know it's not just Joanna who's affected by this, but it's everybody like me, everybody with my condition or my insurance or whatever. So over the past couple of years, as our advocacy has ramped up on this, we have tried to quantify how many people are affected and what the repercussions have been. So the first place to look whenever you're looking for data about the bleeding disorders community is to look at the ASIN data that they collect with CDC. I think there's a session later today about the community count data collection program. So I would definitely check that out because it's community counts data that tells us there are about 1,000 Medicare beneficiaries with bleeding disorders. So that means people with hemophilia, VWD, or a rare bleeding disorder that are included in the H2C network. So that, 1,000 is both a lot of people and not a lot of people. So we have been able to use that in advocacy to say, listen, in terms of the millions and millions of people who are on Medicare, it's only 1,000 of them who have bleeding disorders. So if we try and change this so that these 1,000 people have better access, it's a big change for us, but a small change overall. Then 2 years ago, just coming up, NHS and the Alliance did a survey of HTC social workers to try to dig deeper into how many patients really needed SNF services, how many patients had difficulties accessing SNFs, and then what the effects of this lack of access has been. So you can see on the slide here what the numbers are, but the estimate was for an 18-month period, there were about 100 patients who needed access to a SNF, of which 92% couldn't access it. And you might be wondering, based on what I said, what's the difference? How did some people get access? And I suspect that those are cases when the person did not have Medicare. The 100 was people with all types of insurance. So the rules are different for private insurance, and Medicaid, it varies state by state. So I think some of those people were able to had other types of insurance. I've also heard of patients who were admitted to SNF kind of before the SNF figured out this was going to be a problem, and then didn't kick them out. So decided to kind of accept a financial loss, at least in the short term. So then we asked, okay, so for these, 92% who had trouble, what did the SNF tell you was the problem? So I highlighted in yellow the biggest reasons, and one is about 50% they were unable to infuse clotting factor, that they just felt like they did not have the nursing expertise to be able to do it. And then 58% were concerned about the cost. People who knew that they wouldn't be able to bill separately and that it was just going to be too expensive. But I think this highlights that there really may be two issues going on. SNFs are worried about expertise to care for people with bleeding disorders or to help with their infusions, and they're worried about the cost. And then we asked, okay, so what happens? how have your patients been affected by this? And I'll just kind of quickly walk through each of these. So in 10%, the surgery was postponed. So this is someone who may have, say, a target joint that could be replaced, but the HTC folks, the surgeon, the social worker, et cetera, know, this patient is not going to be able to go home. They're going to need to go into a SNF after. And because we know that's not going to be an option for them, we're just going to hold off on the surgery. And I think we know that the real life impact of that is both someone living with more pain, more trouble with their joint, and much higher factor costs or treatment costs generally. It's funny, I've been around so long, I say factor, even though we obviously have non-factor treatments now for hemophilia, but just roll with me. Know that I'm intending that to be broad. So in 10% of the time, the surgery that would improve a patient's quality of life and probably lower their healthcare costs overall was postponed. So that's really bad, both from a patient access aspect and from a kind of Medicare taxpayer dollars access. So 71%, almost 3/4, the patient is kept longer in the acute hospital setting. So this is where, a patient would otherwise be discharged a couple days after surgery, but they know they can't go home yet, they can't go to a SNF, so they just stay longer. Why that matters for policymakers is staying in the acute hospital, which acute is just a regular hospital, that's much more expensive to Medicare than going to a SNF. So this was a fact that was very interesting to folks in Washington because generally policymakers want to improve outcomes and lower costs. We talked about with surgery postponed, we're kind of working on both of these. For this one, providing access to SNF services will really lower costs overall. The next one, about 1/3 of patients went to another care setting, but they had complications because they needed the more advanced care that is available at SNFs. 61% of the time, the patient just went home, and then folks came into their home. So there was nursing, PT, OT, et cetera, who provided services. And the last one, so almost 60% of the time, patients went home and their families had trouble caring for them. We, working on this issue over the years, have heard some really, really tragic stories about people who went home. Their families weren't able to care for them, and they really suffered pretty serious health consequences. And it's just, that's awful always. But it's especially awful to me when it's like an arcane Medicare payment policy is leading to people being harmed. That's just dumb. We shouldn't let that happen. And so that is what we have spent the last several years working on. So what is our goal? The goal we realized is we had to make it so SNFs could bill separately for bleeding disorders treatments and their administration. Because remember, half, I think, of SNFs were worried about providing bleeding disorders treatments. So we needed to make sure they could get help with both the cost as well as the expertise. So the good news, as we were trying to figure out the precise policy solution, one, we had two kinds of precedents that we could follow. One, every other type of hospital is allowed to bill separately for bleeding disorders treatments. So I've explained what all these different types are, but I think what's most important for you to know is that SNFs were the only kind of facility that wasn't allowed to bill separately for bleeding disorders treatments. So that we've been able to make the case, Medicare, Congress and Medicare have already recognized the need for bleeding disorders treatments to be billed separately because they're so expensive and they're so rare. Your average long-term care hospital, may never have a person with a bleeding disorder. So it's not something that they kind of anticipate. And when it comes to regular hospitals, acute hospitals, in fact, bleeding disorders treatments are the only treatments that can be billed separately from the way every other type of medication is included in how regular hospitals are able to bill Medicare. And that's because of a policy change advocated by the bleeding disorders community in the 90s. So we had a lot of precedents kind of bleeding disorders specific that we could rely on. The other type of precedent is that there are a handful of other things that are able to be billed separately by SNFs. So it's chemotherapy for cancer and its administration, radioisotopes. I'll be honest, I've worked on this for like a decade. I still don't really know what those are, and certain prosthetics. And so there is policy around services that are really expensive, really specialized, and rare. So beyond what SNFs typically provide. And it's called out in the law, you know, these couple of things can be billed separately. And I think just as important, SNFs can also make an arrangement with another provider to provide them. So they don't need to have radioisotope expertise at the SNF. They can contract with the radiologist, presumably, who do. Or they don't need to have cancer expertise. They can contract with a hematologist. So in our case, they don't need to have bleeding disorders expertise. When it comes to providing treatments, they could partner with an HTC. So the picture here is to represent the long and winding road that we have taken. I thought about either this or, you know, we could listen to the Beatles song together. This is an issue that has been around a long time, and we first wrote to CMS, that's the federal agency that administers the Medicare program, in 2005 to see if we could get this fixed administratively. You know, could they, there's already this list of other services that can be billed separately. Can they add us to that? And then we wrote again in 2011. In 2019, NHF and the Alliance wrote to CMS. We also had a meeting with senior staff for SNF policy and who report to the CMS administrator, again, to raise this with them in 2019. And, you know, if you look at the years, we had different presidential administrations in all those years, different perspectives, I guess, on the CMS authority. But in each case, we were told no, that CMS does not have authority to add a new category, but that we would need law. Okay, so then you shift to Congress. We were really close in 2014 to getting a bill introduced, but our lead sponsor, and anyone who participated in Washington Days might remember, our lead sponsor was then indicted and left Congress. So we were really close, but it didn't quite happen. And then, you know, I think this is something that has been on our collective agenda really since 2005. But there have been other issues that seemed more urgent, or we had to be more reactive. So between 2014 and 2019, you know, that was the ACA repeal and replace fight in Washington. You know, there were other big things that kind of took up energy, but this was always on the agenda. And for maybe my third shout out to HCC social workers and nurses, you guys were persistent and impatient in the best way that advocates can be to kind of keep this on the agenda. And so thank you for that advocacy. You know, we talk about advocacy with Congress, you know, with federal agencies. There's also advocacy within our community, and you guys were very effective at it. So finally, we drafted and had introduced the Hemophilia SNF Access Act, which was introduced in January and then February 2020. You can see here the kind of screenshots of the bill. Shout out to Michigan Congresswoman Debbie Dingell, who is who was one of our leads on the bill when it was introduced. I'll say that getting, the House or the Senate bill that was introduced in January was introduced in the midst of the impeachment proceedings that happened that year. So like that was kind of crazy. And then the House bill, we just really, really wanted to be introduced before NHS Washington days, and I think it was introduced the day before. So our long and winding road, we got there with the bills introduced, but it was, it was more dramatic. All of this has been more dramatic than it needed to be. So what did we do last year? There were joint letters of support upon introduction signed by the National Bleeding Disorders Organization. I work with NHF in the Alliance, but HFA, COT, and the Coalition for Hemophilia B have also been just really amazing advocacy partners in that. So I want to make sure they get a shout out as well. The bill was included in both NHF's Washington Days and the Hemophilia Alliance Hill Days that happened in 2020. It was the first time that at the Hemophilia Alliance Hill Day that advocates went beyond educating, but to really be lobbying for something, which I think goes to show the first time the HTC crowd ever did this, that it was on a patient access issue, I think again underscores both the importance of the issue and HTC staff commitment to the community. I know there were lots of grassroots contacts. Individual members of the community sent phone calls, made phone calls, sent emails, reached out to their members of Congress to ask them to co-sponsor the bill to highlight it. And so thank you to everybody who did that. And I'll say on my side, we had about 1 million emails, phone calls, meetings with the bill sponsors and committee leaders to answer their questions about the bill. Lobbying often gets a bad rap. And, there are certainly bad actors, and I won't excuse them. But I think, what we were doing was the good kind of lobbying. And I say that not just because I was doing it, but, we had technical expertise that the bill sponsors don't. They don't know why someone with a bleeding disorder would need a SNF. They don't know, exactly which J code. So Medicare pays for physician administered drugs. I'm getting weedy again, based on things called J codes. So basically every drug that treats a bleeding disorder is assigned a number, and the numbers change every 6 months just to keep us on our toes. And so, they don't know which are the right J codes. That's something that they relied on us for. So there was a lot of behind the scenes work to arm our champions to make the case that this bill should move. And it did, hooray. The bill, you can see it's only this one paragraph, was included in HR 133, the Consolidated Appropriations Act. It was a mega bill considered at the end of 2020 that had both federal funding levels, COVID relief. I mean, it was like 2,000 pages, so it had a billion things in it, including our paragraph. As you'll see, the bill or the change to allow SNFs to bill separately for bleeding disorders treatments and their administration takes effect on October 1st, 2021. So a few months from now, and I'll explain why there's a delay in just a sec. But before I move on, just want to again say thank you to everyone. All good. It's hard for me to think of an advocacy win we've had in the community that didn't involve everybody. So thank you to everybody who was involved in this as well. I think there were some other things that worked in our favor. As I was thinking about the presentation this morning, I was trying to think of this as like a case study, like we went from getting a bill introduced in January to enacted in December, which in terms of Washington policymaking is like crazy, crazy fast. And I want to say that's again because I'm so awesome, but I do think that there were kind of bigger picture things that worked in our favor. The first is we had a lot of precedence, as I talked about a second ago, but this is really a narrow policy change. You know, this massive change for our community is like that is one little paragraph in a 2,000-page bill. So I think that we were able to have data to show, you know, this really isn't very many people, but it really matters to us, was helpful. Also, our congressional champions had close personal relationships with bleeding disorders advocates in their state. And so I think they really wanted to make this happen. I know that the HFM crowd is close with Congresswoman Dingell. Senator Menendez, who took the lead in New Jersey, it turns out the New Jersey chapter's New Jersey lobbyist son is Senator Menendez's state director. And like, they're all close friends. So Menendez was going to make this happen for his friend. Congressman LaHood, who was another lead, his kids are altar boys with a bunch of Illinois advocates who live in Peoria, and they all text each other. So, you know, like we had really close relationships that we were able to rely on, to send texts when we needed them, to make calls, to say, hey, I know there's going to be this big bill at the end of the year. Do you think there's any chance we can be included? And then finally, there was a vehicle. We talk a lot in policy in DC that you got to have a vehicle that's moving for a bill like ours to pass. And I think the fact that it was, technical term, a mega bill was really helpful, because there was so much in it and it wasn't all paid for. That meant that we didn't need to figure out, okay, so if implementing this costs however much, how do we pay for it? I don't want to say we hid in it, because that sounds shady, but I do think that the fact that it was this big bill that included so many things, and that our champions, I think every member of Congress had something they wanted in that bill, and that our champions said this is what they wanted, I think really helped. So what comes next? Just this week, the annual rule setting the rules for SNFs was released. It includes the implementation of our policy change. And the reason why it doesn't take effect till October 1st is that is like the start of the SNF year, if that makes sense. So every year there's this rule and it takes effect at the start of the fiscal year 2022. So we will be commenting on the rule, reminding CMS why this is important, and you know, looking at the nitty-gritty of the J codes, making sure they're all still the right ones. We are also planning to educate the SNFs themselves. They have an association in Washington, and we are going to work with them to educate the SNFs about this change, so that when a social worker calls them, they already know that this change has happened and that they're able to bill separately. And then finally, I think we're planning to do a lot of education of HTCs and chapters and community members about the new policy, because you're going to be the one, it'll be you or your dad or your patient who's told, well, no, I can't take, you know, hemophilia or VWD patients because of this thing. So I want you guys to know, wait a second, that changed. And in fact, now you can. And we know that HTCs and chapters, you guys are the ones who get the phone calls from individual patients and families. So I want to make sure you're equipped with what you need to respond to that. And then finally, just wanted to highlight again, like what this really means in like technical policy stuff is that there are certain J codes that can be billed separately. And as I mentioned, they change. And so it's our job to make sure like those are the right J codes, you know, and it's not just hemophilia. Again, it's hemophilia, VWD, or rare bleeding disorders. And then the Secretary of HHS has authority now that we're in now that we have a category, we can advocate for new products to be added moving forward. So this is what reflected the kind of landscape as of last July. But if some super awesome new product were to come on the market, actually it wouldn't even need to be super awesome, just a new product came on the market, we would advocate to make sure that it's included moving forward. So the idea is now this becomes like a kind of a living policy, something that we'll work on each year. And I think, yeah, that is my last slide. Wanted to share my email address. Many of you know my partner in crime and at my firm, Ellen Riker, who has worked with the bleeding disorders community since the late 80s. We are just so honored to be, the community's part of the community's voice in Washington, and thank everybody for hopefully hanging through all those weeds. Because I think, some of you care about the policy details, I'm sure, but I think what's universal is how powerful the community's voice can be when it comes to advocacy. And this is just one example of dozens and dozens over the years. And so just wanted to, again, thank everybody for being such strong advocates all the time on this issue and many others. And with that, Sarah, I guess I'll stop sharing so we can do Q&A. Is that okay?
Yep, that works.
And then
so
we can see who's here.
Yeah. I do want to say again, thank you so much. I remember it was at a SpringFest, maybe my first or second year at HFM, when a community member came out to me talking about this issue, right? So thank you for that, because I know people are really going to be impacted by it. We do have one question, and I do want to do a little shout out. We have a few HTC social workers here, so yay for them. Ellen did have a question about can you get a cheat sheet to use when in communication and contacting SNFs?
Oh, totally, Ellen. And you have been one of our staunchest advocates on this issue over the years. So thank you both for keeping us honest. And I know all the advocacy you do for your patients all the time. But yes, I do think we will come up with a cheat sheet for you guys to use so that you know kind of which products and which patients to help with SNF. So yes, I'll make sure that's on the list of education stuff. And if there's anything else that you think would be helpful, let me know.
Great, thank you. Thanks for having us along for that ride.
The long and winding road, yes.
Yeah. We did have a question. This was from Amy, and Amy, maybe you can clarify this. Should we have our doctors know of SNFs? I think if you're willing to clarify, that might help us out, Amy. I also wanted to share, again, and I know Joanna mentioned this at the beginning, but if you had other questions about anything going on in Washington and at the federal level, this is a really great time to ask those questions, since we have Joanna here with us, and she's definitely an expert in that area. Okay, we have another question. From Susan, should we have basic education documents for the staff of the SNF?
Yeah, and Susan, I know we spoke a little bit before we got started about wanting to make sure that SNFs really are a safe place for our community. And yeah, I think that we, as I mentioned, plan to try and educate them via their association. I think in practice, I suspect it will often be HTC folks educating their local SNFs, just like you guys do for all the facilities and schools and everybody near you who aren't as familiar with bleeding disorders. But I do think the fact that SNFs will be able to contract both for actually providing the treatment, but also for its administration, they don't have to be ready to, infuse factor, that they can work with a partner to do so, I think will help with that.
And Amy shared clarification, and maybe Ellen or Dave on the line can speak to this question. Should the regular, maybe their PCP or other doctor have knowledge of this type of aftercare? Ellen, I feel like you might be able to speak to that.
Yeah.
The more that know, the better. Because, in the HTC, if somebody's admitted, we usually go over and follow along with them and along with the discharge planners. But the more that know, the better, because of all the issues we've had in the past.
Well, and Ellen, I'm curious, like, how do we get to discharge planners? Like the SNFs have an association, or is it providing information to HTCs that then you share within your institutions or your partners?
We would share it with our case managers, and
Cool.
probably for us, most specifically with the discharge planners and case managers that our patients are most likely to be on the units for.
Sure.
Yeah.
That makes sense.
Yeah, hi, this is Dave, Traverse City. I'm also a social worker. Hey, Joanna.
Hey.
We do the same thing as Ellen when in our HTC, if in the event that we have anybody in the hospital, which, thank God, literally, it's very rare. But we would work with the case managers and the discharge planners as well, but we would be really involved because as the HTC social worker, because they just don't have any experience. So, we've only had a couple cases, as I'm sure you've probably heard over the years, that were discharged literally overnight once they found out the price.
Mm-hmm.
So,
Mm-hmm.
But yeah, thanks for all your work on this. This is just amazing. It's great. We really appreciate it.
Oh, it's been my pleasure.
I second that. It's been horrendous.
Well, and I mean, jokes aside, there were obviously many, many people involved in this. So I will take your thanks on behalf of everybody who was involved. But yeah, I mean, we were thrilled when, the bill passed on December 21st. I think they released the text on the 20th. We were back and forth with the staff as late as the 19th. And so when the text came out and we saw that we were in, it was like the most exciting thing that happened to me in 2020. And 2020 wasn't a great year, right? But still, it's pretty wonderful. Megan, did you want to chime in?
Oh, yes, thanks. Sorry, I didn't want to accidentally speak over anybody. I had a question about how the SNFs ended up being uniquely in this situation as opposed to the long-term care hospitals, and especially the psychiatric hospitals, which tend to be very overwhelmed and stressed out by anything remotely medical.
Yeah, so that's a great question. So I think the way that it happened is to have regular hospitals be able to bill separately for then factor, bleeding disorders treatments, was because of a law that was changed in the 90s. And I think that the long-term care, the IRFs and the psychiatric hospitals kind of followed that precedence, I think, on their own, that Medicare was like, oh, hospitals can bill separately, if that makes sense. And then when the SNF policies were being created, I think it was when, as a community, we were pretty focused on Ricky Ray. And so I don't want to say that we missed it, but I think we were focused on other things. And, back then there were relatively very few folks on Medicare. So it's been a problem that's been growing and, will only continue to grow as folks age on. So it was just this kind of weird thing that they were different from everybody else. And I think that was helpful in our advocacy when we could point that out.
So if I can clarify that for you, Megan. So hospitals can bill Medicare Part A for inpatient, but clotting factor is billed separately. It's an exclusion to the DRG rate, so they can bill the factor under Part B. SNFs have never been able to do that. They were always Part A, which is what led to difficulties with having patients in nursing centers where they'd either outright reject them, or if there was a way around it, have the family bring it in. It led to some sticky situations.
Got it. Thanks. That makes more sense.
Love having Ellen and Dave here as well. Thank you.
Mm-hmm.
Joanna,
Do
what
we
else
have-
should we be looking at right now? Anything interesting? You said you can give us some what's going on in Washington info.
Dangerous question. What else is going on? So Congress is just starting the federal appropriations process. It's been delayed this year because President Biden still hasn't released a budget. Often when there's a new president, so in normal years, the president's budget comes out in February. Often when there's a new president, it slips to March. But I think they still don't have a director of the Office of Management and Budget. So that's been slower to start. So the kind of congressional process is just kicking off. So we are advocating for the CDC program, the HRSA program, as well as funding for bleeding disorders research at NIH. So that's something that's been taking up some of my time lately. Those of you who came to Washington Days or saw advocacy around it know that we were supporting a letter to the Biden administration asking them to prohibit accumulator adjuster programs. And I'm happy to explain what those are if anybody is not aware. But so that letter ended up getting 58 signatures from House members, which is awesome. Was really thrilled with the response. And again, thanks to everybody who was working on that. So that letter was sent over to President Biden, and the members of Congress are kind of waiting for a letter back. And in the meantime, we've started to draft legislation to prohibit accumulators that, I think could have a tougher road in Congress. So the point would really be to put pressure on the administration. They have the authority to change this policy. And so the more members of Congress who say, I care about this and you should change it, the likelier that is. So
Joanna,
that's something
can I
that we're
jump in
working
there
on.
for a second? So through executive order?
Oh, no.
Or
So
how?
through the annual, this is why I don't know why anybody
Through
invites me to
CMS?
this. Through the annual notice of benefit and payment parameters rule. That is the rule that sets the rules for private insurance plans each year, stemming from the ACA. So that's the rule where they could say, no, accumulators aren't allowed.
And do you think that, what do we feel hopeful that we could get the administration to do that?
Yeah, I think there are plenty of reasons to be hopeful. I think President Biden talked a lot about patient out-of-pocket costs, and wanting to address those. So I think that's great. I think our biggest hiccup is some more technical legal issues about the rules for high deductible health plans. And lawyers at the IRS fighting with lawyers at HHS, and that we can't really solve. So I think that is trickier. But I think, and I should also mention that NHF and HFA are working with lots of other patient communities on that too. That doesn't just affect us; it goes broader. So yeah, I've been working on that legislation. I'm trying to think what else. The Hemophilia Alliance Hill Day is coming up in just a couple weeks. And the folks there will be talking about educating about 340B program, why it's important to HTCs, wanting to kind of caution Congress about making policy changes that could negatively impact HTCs and their 340B programs. And we're also going to be talking about the kind of latest, in the game of whack-a-mole of trying to ensure patients have what they need, the latest challenge, which is that some big companies are just dropping coverage of hemophilia products altogether, or bleeding disorders, I should say, and then trying to shift patients onto manufacturer assistance programs, which is just, weird and I think unethical, but I'm not sure it's illegal. So kind of educating about that issue to try to lay the groundwork for trying to tackle that this year too. Always plenty to do.
Anna, do you think the pharma manufacturers will fight back against that? That's not the goal of their patient assistance programs, to be,
Totally.
on it forever.
Totally. Yeah, I think they are. But, if you're the biggest companies that are regulated by a law called ERISA, have a lot more flexibility with respect to how they set up their plans. So it just makes it harder to fight. I understand, I haven't talked with any of our pharma folks, but I know some of my colleagues have, that they also worry if they were to, say, restrict their assistance programs more, like, could that cause access issues in and of itself for people who really need it? So it's a sticky issue for sure that I've only been working on the past couple of weeks. So I suspect you guys will hear more. And I don't say that to scare anybody either. There's always another access challenge, but there are a lot of people working on it.
So Sarah, do you want to share what we're doing in the state a little bit with, and Joanna, that kind of relates to these same areas, these same issues?
Yeah, well, before I get there, I was just going to clarify and ask another question about that issue, since Sue and I, and we've talked about that a bit. So do we think that it really is just limited to these self-funded plans, and so therefore really focus on the federal side?
I don't think it's exclusively, but I think predominantly, yeah, ERISA plans.
Okay.
So yeah, I think it's more federal than state, at least for now. But I think the concern is, well, and there are more rules around state regulated plans, and the ACA protections. So
yeah. So, and I was going to mention, related to copay accumulators, do you think the fact that a lot of states are pushing legislation would also put pressure on the Biden administration for change?
I think totally. And I think it really helps with advocacy with Congress too. Members of Congress are likelier to co-sponsor a bill when we can say, back home, Michigan passed this law that's pretty similar, but that can't get at everybody with a private plan. We need Congress to act,
Yeah.
I think that has been super helpful over the years.
Yeah, and so for anyone on the line who is not aware, HFM has been quite involved in working to pass copay accumulator reform in Michigan. So as we've been mentioning, that would only impact, like state regulated plans, and so not some of these other self-funded, those big employer plans. But HFM has been working with a really large coalition called the Michigan All Copays Count Coalition, which sort of comes from the national All Copays Count Coalition. And we are very happy to share that we did get our bill passed through the House, the Michigan House. And so, yes, it feels like a really good win. Of course, we are now moving to the Senate, and so we'll have to do the same work of working with our bill sponsor and a lot of meetings and education, and then working through committee, and then through the full Senate, and then of course onto the governor's administration. So, there'll be much more about that, and please look to our event calendar. We do have another webinar on that on May 20th, and we'll have Colette from the National Hemophilia Foundation coming to speak on that again. And I'll of course be there as well to give that state view. So that's very exciting.
That's awesome.
Thanks,
You're
Ellen.
such an advocacy rock star.
Thanks. It means a lot coming from you, Joanna. I do want to mention that we have 3 more minutes. Are there any other questions we'd like to ask Joanna before she leaves? Of course, you can always email. Joanna shared her email, and you can email myself as well. Anything else?
So is your dog there with you today?
So my husband thankfully closed. I work out of our basement in COVID time, so he closed the door. So Indy will not be joining us today for the session. I have a 90-pound rescue lab who's like enormous and love of my life. Don't tell my husband, but he can be rambunctious during calls. So
I know
he's
the
upstairs.
desire to, keep things so professional for these presentations, but I do love seeing a little dog pop in.
Yeah, it's fun.
No, me too. That's been a fun part about everybody being home.
Yeah.
Sure.
I also wanted to share something that Joanna said is Joanna also got a box as a SpringFest speaker, and she was playing with those airplanes with some of her friends and kids. So,
yeah, they were
yay.
so fun. Both all of the 30s and 40 somethings as well as all of the children were equally enamored of the paper airplanes, and we did tests of how many pennies to put in and what if it was 1 versus 2. It was super fun.
Science.
So thank you.
I love it.
Right. And thanks for just including me in your conference. Talking to bleeding disorders advocates is one of my very favorite things to do because you guys are so super effective and super inspiring. So I think, the policy details aside, again, I think the SNF story is an example of when we all advocate together, we can do some pretty amazing things. And so hope you will join Sarah in her effort on the state level. Hope you will come to Washington for Washington Days sometime. And just know that your voices really do matter and are needed to make changes that we know everybody needs.
I really appreciate that, Joanna. Thank you. For those of you who stayed with us this whole time, thank you. You get the code word now. For those of you playing Goose Chase, the code word is MAKE, M-A-K-E. I'll type it in the chat as well. So thank you for sticking with us. We really appreciate it and hope you're having fun through Goose Chase. And one other thing to share, please take a chance to fill out the evaluation. If you go back to Socio, go to the agenda, find this session again. If you click the session description, you should see a link. It stays right in Socio. It just pops up as a little jot form survey. We really appreciate that just as planning programming in the future. And so with that, this is perfect timing. I'm so punctual. I'm not punctual, Joanna. Good job. It's 12:05, so thank you all so much. Please go back to the main stage and we'll all meet there on Socio. Thank you, everyone.
Awesome.
Thanks,
Bye, everybody.
Joanna.
Thanks so much.
Yay.
Bye.
Thanks,
you all.
everybody.
Good to see you guys.
Bye.